Good afternoon, everybody, and welcome to our Women's Wellness Q&A with Dr. Marlena Masavage, a board-certified OBGYN with our Beaufort Memorial Obstetrics and Gynecology practice, now seeing patients at our new Okatie Medical Pavilion and in Beaufort on the hospital campus as well. We are so happy to have you, Dr. Masavage. Thank you for being here today.
Yeah, thanks for having me. I'm excited and nervous, but excited.
Don't be nervous. You're the expert here, so you know more than any of us. So we have questions from a number of women in all ages and stages of life. So this should be a really interesting conversation. And we've got about 20 minutes, so I'm going to go ahead and jump right in.
Okay.
Our first question is, what should I do about a painful period?
Well, most women, by the time they're asking this question, have already tried the normal things like Midol, ibuprofen, heating pad, that sort of thing. So after trying those basic things, I recommend going to talk to your gynecologist about it, making sure that you know the details of like how long your periods are, when they're painful, how painful they are, if they're interfering with your work or daily life, so that we can evaluate you and hopefully help you out. We'll probably do a pelvic exam after taking your history. Sometimes we'll do an ultrasound to evaluate for reasons that you could be having painful periods. Sometimes, unfortunately, they just happen without a cause. But sometimes things like fibroids or endometriosis can cause painful periods. So we'll want to evaluate for those things so we can kind of get down to the bottom of it and help treat patients for it.
Great, thank you. The next question is about pregnancy. What should I do if we're ready to get pregnant?
So some of that depends on your age and if you have any other risk factors during pregnancy. All women should make sure that they're already taking a prenatal vitamin as soon as they stop using a birth control or think there's a chance of them conceiving, because the first 6 weeks of after conception is actually the most important for the folic acid to work. That's in a prenatal vitamin. So taking your prenatal vitamin is key. It doesn't matter which one you take. I personally take a gummy vitamin because those are fun and taste good, and I'm more motivated to take them than the big old horse pills. But taking a prenatal vitamin is very important, so you're getting the nutrients that your baby needs. And then for some women, they really do need to talk to their OBGYN before they actually conceive, especially if they have other medical problems like high blood pressure, diabetes, seizure disorders, just to make sure that we've optimized those health issues, make sure that you're on the right medicines that are safe during pregnancy instead of trying to scramble after you already found out you're pregnant, trying to switch your medicines, just trying to optimize everything so that you can have the healthiest, safest pregnancy.
That's great, thank you. When should I start getting mammograms?
So for most women, the guidelines are to start annual mammography at age 40. And then depending on the guidelines you talk to, they either say annually, so mammogram every year, definitely between ages 45 to 55. But for most of my patients, I recommend an annual mammogram from 40 until they stop screening. And some patients, if they have risk factors for breast cancer, such as a strong family history of breast cancer, if they're positive for like the BRCA or BRCA mutation, they may qualify for earlier screening as well. For those patients, many times we recommend starting to screen via mammography 10 years before the family member had breast cancer. So for those patients, that might be in their 20s or 30s, if they had someone like their mother that was diagnosed when they were in their 40s. So that's important to discuss with your provider too, so they can get your screening at the right time.
Absolutely. Let's see, the next question is, what can be done for painful intercourse?
So first of all, it's important to find out why someone's having painful intercourse. Sometimes it can depend on the patient's age. So what causes painful intercourse for younger women, reproductive age women, oftentimes can be different than what's causing painful intercourse in menopausal women. Many times for menopausal women, it can be vaginal dryness that develops after lack of estrogen, after going through menopause. That's treated differently versus women in their reproductive years. Sometimes it can be endometriosis or something like that. Sometimes it can be tight pelvic floor muscles or spasming of those muscles, which can be helped with pelvic floor physical therapy. So it's definitely important to get evaluated to try to identify the actual cause of the painful intercourse. Because we don't treat it all the same. It's definitely tailored to the specific patient and their specific problem and needs.
And the next question is somewhat related to that. I think I'm menopausal. What can I do for hot flashes, vaginal dryness, and decreased libido?
So one option that, there's of course several options to treat those symptoms of menopause. For patients that are candidates and are interested in hormone replacement therapy, those usually treat those symptoms the best. And hormone replacement therapy is very effective at treating those symptoms, but it's important to meet with a provider, discuss your personal risk factors that may make you not be a candidate for hormone replacement therapy, such as personal or family history of breast cancer, personal history of blood clots, those types of things. But we can either do systemic hormone replacement therapy. So that's like a pill or a patch with estrogen and progesterone. Patients who've already had a hysterectomy only need the estrogen without the progesterone. So it might be a little less risky for those patients. And then if they're not having the hot flashes or night sweats and they're just having the vaginal dryness, then we can do more targeted vaginal therapy to try to decrease the risks of the systemic therapy of estrogen. But still relieve their symptoms, which is an important part of life is vaginal dryness, and that what goes with that, which sometimes can be frequent urinary tract infections or pain with intercourse. There's also non-hormonal options too for patients that either aren't candidates for hormone replacement therapy or just choose to not accept the risks that sometimes can be associated with hormone replacement therapy. So there's over-the-counter medicines that patients can try. I know I have several patients that take estrogen or black cohosh, and that sometimes can control their symptoms. We also have prescription medications that are non-hormonal, such as Paxil or Effexor, even gabapentin. There's several that we can try for a patient depending on their personal symptoms and risk factors and health history to try to get them the safest, the most effective treatment for their symptoms.
Okay, very helpful. The next question is, I've had 2 miscarriages, both around 7 or 8 weeks. Should I try to get pregnant again?
I'm sorry, you said 2 miscarriages?
2 miscarriages,
Okay.
both around 7 or 8 weeks.
Okay.
Should I try to get pregnant again?
So after having 2, especially consecutive miscarriages, we usually recommend coming in for an evaluation to try to identify if there's a reason that a person is having a recurrent miscarriage. Usually, if you just have 1 miscarriage, that we can chalk that up to just a spontaneous thing that happens. It's not related to anything that would be recurrent or cause another miscarriage, because miscarriages are very common, unfortunately. But many women can have 1 miscarriage and then go on to have a normal pregnancy. After 2 miscarriages, we can actually recommend lab evaluation and sometimes ultrasound as well to try to rule out any factors or causes for the miscarriage that we could prevent, because of course the last thing we want is for a patient to keep going through the heart-wrenching experience of experiencing miscarriage after miscarriage. So you don't have to come see us, but there are at least tests that we can run, things that we can do to try to prevent another miscarriage from happening.
Yeah, I think that's more common than many women think. So
yeah, definitely whenever I see patients and they've had a miscarriage, sometimes they've actually had friends and family members step up to let them know that they've also had miscarriages too, which is really helpful for them because a lot of patients feel like they're alone in that. And unfortunately, that's not the case. It's a very common thing. But most women do go on to have normal pregnancies. So that's the encouraging part of it, is that just because you have one or even two miscarriages doesn't mean you're doomed to always have miscarriages. Many times we can have a nice healthy baby after one or two miscarriages.
I think that's very comforting to a lot of women. Okay, so the next question is, sorry, lost my place here. Here we go. How old is too old to get pregnant?
So from the physical standpoint of being able to get pregnant, as long as you're having periods and ovulating, it's still possible to get pregnant. So for my perimenopausal patients out there, they're wondering how long that they need to be on birth control or doing something for contraception. I'm like, well, as long as you're having periods, there's still a chance. Of course, it does get harder to conceive as you get older. And we do consider age 35 and over to be advanced maternal age, which I hate that term because I personally fall into it, but that's okay. But those patients after age 35 are considered to have be more at high risk for pregnancy complications. So that doesn't mean that they can't get pregnant or shouldn't get pregnant, but just that they may need closer monitoring during their pregnancy to look for things like high blood pressure and preeclampsia in pregnancy, gestational diabetes. Sometimes stillbirth can also go up as well. Risk of Down syndrome and other aneuploidies can also increase after that age. Excuse me. So like I said, it doesn't mean you shouldn't get pregnant after that age. It just means that you just need closer care. And then for some women, it can definitely be harder to get pregnant after that age as well. So for patients who've not gotten pregnant to that point, especially if they've been trying, then we'll work with patients for infertility or refer them to the infertility specialist in Charleston, usually Coastal Fertility, to help with actually conceiving if they're having an issue after age 35, since it can be harder. And then once they do conceive, if they were transferred to Coastal Fertility, we get the honor of having them transferred back to us to take care of their pregnancy and help deliver a healthy baby for them. So yeah.
That's fantastic. So the next question, also related, how long does it typically take to get pregnant?
So we usually call infertility, or we define infertility as inability to conceive after 1 year of trying. And that's for women under the age of 35. After age 35, since we do get concerned about higher chance infertility, if patients haven't gotten pregnant after trying for 6 months, that's when we recommend that they come in for evaluation because we don't want them to defer pregnancy longer and make it even harder to get pregnant. So most women will conceive within that first year of trying. And then, like I said, I always encourage women, if they already have a known reason for possible infertility, such as PCOS or polycystic ovarian syndrome, or if they're over age 35, to come get evaluated sooner after 6 months, because those patients are at higher risk of needing a little bit of help to conceive.
Okay. Let's see. I had a C-section with my first child. I would like to try to deliver my next child vaginally. Mm-hmm. What are my risks?
So the main risk that we always focus on or talk about, I guess, the most about trying for a vaginal delivery after one C-section is there is a small chance of that scar on the uterus where we did the first C-section. That scar can actually open up during labor. It's called a uterine rupture. It's not very common at all. It's 1% chance of happening per pregnancy. But if it does happen, it is considered a medical emergency because the baby could actually deliver through the scar. So any woman that happens to would need an emergency C-section. So that's the one we worry about, just because, like I said, it's not common at all. It's very uncommon, fortunately, but it can have big consequences on the mom and the baby. Other things that we think about are reasons why a person had the first C-section. There's actually an online calculator that we can access that puts patients' specific demographics and risk factors into it, such as if they've ever had a vaginal delivery, why they had their C-section. I think there's a couple of other ones too, but it actually will calculate kind of their chance for success for a successful vaginal delivery after a prior C-section. So I'll use that to also counsel my patients as well. For example, someone who pushed for 3 hours and then had to have a C-section, that patient may be less likely to have a successful vaginal delivery than someone who just had a scheduled cesarean section for a big baby or for a breech baby. So it's definitely something that I talk to each patient individually about what their first experience was, if they were allowed to labor or not. But that is the main risk factor that we think about. On the flip side of that, of course, there can be risks with multiple C-sections as well. We usually counsel patients that they should not try to have more than 3 or absolute most 4 cesarean sections, because where that scar is on the uterus gets thinner and thinner each time. So you can actually have issues with the placenta implanting over that scar and causing issues and high-risk problems. And then, of course, every time we do a C-section, we're creating more scar tissue from surgery. So that can also make it harder as well. So there's definitely pros and cons to both, having multiple C-sections versus trying for a vaginal delivery. Because of the small risk of the uterine rupture, I did also want to mention that is why we have in-house anesthesia at Beaufort Memorial Hospital. And then if we have a patient that we know is trying for vaginal delivery after cesarean section, the MD provider is also in-house as well until that patient delivers, just to make sure that if an emergency delivery is necessary, we can perform that as quickly as possible for the health of the mom and the baby.
Very good to know. Thank you for mentioning that. Switching gears just a little bit, what will help if I pee a little bit when I sneeze or laugh?
Oh, I get asked this question a lot, especially from women after they've had babies, because of course the pelvic floor muscles are not as strong as they used to be after having children. So there's different things that women can try. It also kind of depends on the severity of their urine leakage. So if it's early on, I talk to patients about doing Kegel exercises, which is where you where you squeeze the muscles that usually kind of hold your urine in your pelvic floor and hold it for 10 seconds and then relax. They say you're supposed to do 50 to 100 of those a day, which sounds like a lot, but you can do them almost anytime, anywhere. No one knows that you're doing it. But those will actually help kind of work out those muscles and strengthen those muscles to kind of help support, because those pelvic floor muscles are what's directly below the urethra and can actually help hold that urine in. So that's something easy that patients can do on their own without any other intervention from a provider or having to go to see the doctor to help. And then if it's worse, if they're trying Kegels and they're still having issues, then I would recommend them coming to see a gynecologist to discuss. Sometimes we can actually prescribe pelvic floor physical therapy, where they do more than just the Kegels to help strengthen those muscles. Sometimes if it's bad enough and they're done with childbearing, there's also surgeries they can have done. They can get a small little mesh sling actually put in. I kind of describe it as a hammock underneath their urethra to help support their urethra, so they won't have that bladder leakage to deal with. And then something else that I've talked to patients about, especially if it's mild or if it mostly happens if they exercise or when they exercise or they're being active, is Poise makes these little, they almost look like little tampons called the Impressa, but they're like urethral tampons. So you put them inside the vagina, but they actually are designed to kind of help support the urethra. So that way, if like I said, if it's not happening every day, if it happens more specific activities, they can put one of those in, and that can also actually help some with the bladder leakage, urine leakage as well.
Okay, very good to know. We've got about 1 minute left. So one last question, and then we're going to have to wrap things up. Does cranberry juice really help with UTIs?
No. Probably not as much as water does. I mean, it can help flesh out the system a little bit. Like I said, I would do more just plain water, honestly, if you think that you might have the start of a bladder infection, you're trying to ward it off. But it's not really going to do a whole lot. I know the azo cranberry sometimes can help just because it has the azo in it and the protein in it too. So that helps kind of numb the bladder so you don't have your UTI symptoms. But just drinking cranberry juice is not really necessarily going to help as much. It's more drinking water. And also once you have actual symptoms, you most likely need an antibiotic for treatment, because if you actually have a bladder infection, no amount of water or cranberry juice, unfortunately, is going to make it go away.
Thank you so much. That's very great information. And we just want to thank you again for joining us today. And also want to thank our viewers and listeners on Zoom and Facebook. If you have additional questions, you can certainly call Dr. Masavage at Beaufort Memorial Obstetrics and Gynecology Specialist, and she is accepting new patients in both Okatie and Beaufort. The number is on the screen, and we just appreciate you joining us today.
Yeah, thank you so much. Yeah, thank you so much. It was fun.